Hello, my name is Christopher Chunseely, and I'm the Program Director for School and Justice Initiatives for the APA Foundation. And it is my pleasure to welcome you to this virtual screening event for Ernie and Joe Crisis Cops. I hope that everyone attending tonight has had a chance to watch the gripping documentary. Communities across the country are grappling with the way in which we respond to our community members in crisis and the unfortunate, tragic loss of life that is experienced when a community member having a mental health crisis is met with a crime and punishment response. We'll be starting tonight's event by sharing with you a brief 25-minute version of the film, just in case you did not get a chance to view it. I do want to stress that in some of the images that you will see, they will be hard to watch, as we know that 1 in 5 people have had a mental health concern or have had some sort of connection to a mental health concern. So if you need to take a moment, please do so. It's all right if you need to step away. You still have access to the full documentary for 2 days after this recording. And throughout the presentation, we'll continue to place the crisis hotline number in the chat, just so you have access to that if you do feel at any point in time that you need to reach out to somebody. We want you to know that you matter. I'm going to pause the recording now, and we are going to go ahead and share the 25-minute clip with everyone, and then we will come back for our panel discussion. That I hope everyone has had a chance to see the full documentary, because I think that clip is a good taste, but I think there's just so much more content and so much more work. And I think the last comment there that Joe was making is, and when we talk about this, when we do some trainings out in the community, is that a lot of times we have to walk community members, 15,000 times sometimes to the support that they need, and it's up to them to really engage. And I think the documentary in its full and its entirety really gives a great sense of what that work can be, and truly what mental health and substance use recovery is such a journey for our community members, and what a compassion and empathetic response can really do for them in helping them in that journey to not just get that initial connection to care, but really stay connected to care. So we are really excited to bring to you this panel discussion. So just a little bit of housekeeping here. To ask our panel a question, please just utilize the Q&A feature at the bottom of the screen. If you have if you have any issues at any point with your questions, we're going to try as best as possible to get to your questions and as many as possible. But if we don't, please don't hold that against us. We also will be recording and are recording this event right now. So if you happen to lose your connection at any point in time, please don't worry about it. We are recording, and this will be up on the foundation website probably within a week. It is now my honor to introduce to you our expert panelists for this event. First, I'd like to introduce Ernest Stevens, who served as a police officer for over 28 years, recently retired from the San Antonio Police Department, where he served for 25 and a half years. Stevens was a founding member of the San Antonio Police Department Mental Health Unit. He holds a bachelor's degree in criminal justice. Stevens has been featured on Nightline, NBC's A Different Kind of Force, and the Emmy Award-winning HBO documentary Ernie and Joe Crisis Cops, which we just got a little teaser of. He currently speaks to other police departments across the country and is a law enforcement trainer for the Naval Security Forces. Thank you again, Ernie, for joining us tonight.
It's my pleasure. Thank you. There's certain events that show up on Joe and my calendar. And when this one showed up, it was pure excitement, to be honest with you, because this is such an opportunity and an honor, to speak to the American Psychiatric Association Foundation members and guests and panelists here tonight. And I'm hoping that, the conversation goes all over the place. I really appreciate the support that you have that you've shown for this documentary. it just seems like it's just continuing to snowball and gets bigger and bigger. And if we think back now, it's like, wow, the film was released almost 2 years ago, and it just seems like we're busier now than we ever have been with the film, which tells me that communities and members of the mental health community, say, hey, this is a priority. This is something that's long overdue. These are conversations that we haven't had in the past that we can now have, or whatever the reason is, right? So this has really provided us a platform and an opportunity to talk any and all things mental health, whether it's within law enforcement and the stigma of asking for help within, or going out and saying, hey, there's a better way that we can connect with members of the community through law enforcement and provide the help and treatment they need. So thank you for having me here tonight, and I look forward to tonight's discussion.
Thanks again, Ernie. Next, I'd like to introduce Joe Samaro. He's a decorated combat veteran from the United States Marine Corps. He honorably served 2 tours to Afghanistan and Iraq with the 1st Battalion, 4th Marines. In 2005, he joined the San Antonio Police Department, where he became one of the original members of the San Antonio Police Department's mental health unit, which Samaro helped to grow into a nationally recognized best practice policing unit. In addition to being one of the main subjects in the documentary we just watched, Samaro has been featured in multiple media outlets, including TED Talks, I See You, which is great. If you haven't seen it yet, please go out and do that after viewing the rest of this event. He is the founder and CEO of Solution Point Plus, a national training and consulting firm that focuses on cultivating mental wellness to maximize human capital and promote safety within organizations. Thanks again, Joe.
Thank you, Chris. I appreciate it. And I am super excited to talk to this group, and I look forward to answering any questions that I can. Thank you so much.
Thanks again, Joe. And finally, I'd like to introduce everyone to Dr. Tony Thrasher, who is a board-certified psychiatrist employed as the medical director for this crisis services branch of the Milwaukee County Behavioral Health Division. He received his psychiatric training from Washington University in St. Louis, Barnes-Jewish Hospital, and he is the current president of the American Association of Emergency Psychiatry. He is a distinguished fellow of the American Psychiatric Association, and he currently serves as the president-elect for the Wisconsin Psychiatric Association. Additionally, he enjoys teaching as a clinical associate professor with the Medical College of Wisconsin and serving as the chair of the Wisconsin State Task Force, combining leaders in emergency medicine and psychiatry on topics affecting improving the patient experience. Thank you again, Dr. Thrasher, for joining us.
Thank you for having me. As someone who has seen this documentary multiple times, it's a real honor to be on the panel and talk about something so important, particularly in a collaborative environment.
Well, Dr. Thrasher, since I introduced you last, I am actually going to give you the first question to kick it off with you. So given your clinical experience, what do our community members who are experiencing a mental health crisis deserve when they need support services?
I think the first thing that you saw in the documentary is always compassion, arriving in a compassionate place, getting your headset ready for a compassionate encounter, and really understanding that you have to meet the patient where they are. Every individual can have a crisis, and the crisis is very personal. They aren't all one size that leads to every single thing going the same way. So I think compassion and being willing to personalize your response is very important. I also think there's a need for a rapid response, which is something has been publicized much as of late. You want to get on scene and help the person as quickly as possible. But then what I really liked that they showed in the film was once you're there, take your time. And that's one of the hardest things to do, I think, when you come from the world of first responders, emergency medicine and other fields, is you're often taught to prioritize rapidity and how quickly you can accomplish things. And when it comes time to working with somebody who's having possibly the worst day of their life, the worst thing you can do is rush it. So the key is to get on scene fast and be there for the person, but at the same time to take your time. And you really saw how nicely that played out. In particular, when people are in crisis, it's not uncommon for it to be difficult to even think about some of the most basic things. I loved the clip on the bridge where she said very clearly, I can't think right now. And that would be a common thread for any of us when we were in crisis. So the fact that people take their time, compassionately meet somebody where they are, not where we want them to be, not to lead with what we think they need or what resources we've heard they might need, but you heard at least 3 or 4 times that encounter, how can we help you? What do you need right now? And I think if we stick to that model, that is what people in crisis need anytime.
I'll just, if you don't mind, I'll piggyback off that just a little bit, because what you say is so valuable. In police academies, and I'm sure Joe will agree with this, we're taught a specific standard response, right? We are to show up, take control, don't show emotion, and handle the situation quickly and get back in service. And there's very little real customer service that goes along with that. When the CIT training came along, and we took it and understood the importance of empathy and taking time and showing compassion, and then taking that training out to the police academy, it was very foreign to the academy staff out there. We actually had resistance from some other instructors that would say, hey, forget everything they taught you, they're going to get you killed, you need to listen to us. So you make such a valuable point there, and I hope people are listening to this, because the antiquated type of policing and training that's been done in the past, I hope leadership is waking up and paying attention to say, there's a better way to do this. And it starts with the approach and really leads into empathy and connection. So thank you for saying that.
Absolutely. We see the same thing a lot in our trainings with emergency departments and emergency rooms, where everything is really set up to not provide a crisis response because they're used to doing other things. But the good news is compassion wins. And I think people can be taught these things, and you've seen success with that. We've seen success with that. And I think sometimes just meeting people on a human level, just to pull some other quotes out that you guys used, one of my favorite is, I care. You don't think about that a lot when you think about emergencies. Usually when I'm administering CPR to somebody who's having a heart attack, I'm not at the same time telling them I care about you. But it really does break down the barriers. And it reminds people what you're there for. I'm not there because you're doing something wrong. I'm not there because people keep calling 911 on you. I'm not there because you need to conform to some sort of protocol that I think you need to. I'm there because I care about you. And it looks like you are having a really difficult time. How can I help? That really reaches people, as does at least 3 different times in that short 25 minutes, you guys thanked people for their cooperation. And that goes a long way, because very often when people are in crisis, they're not used to having gratitude shown them in that context.
Go ahead, Joe.
I was just gonna, on that last point you just made, Doc, is, when I teach this stuff, I tell people, like, saying please, thank you, and I'm sorry are some of the easiest, most powerful, profound things you can say, but it's so counterintuitive because it goes against what most of them are trained. And it's so simple, but we take it for granted. And a small anecdote I share was, heartbreaking, but I had a cadet last year, 2 years ago, in San Antonio. We were training, and he comes up to me after one of the role plays, and he's like, "Hey, Officer Smaro, am I allowed to am I allowed to say I'm sorry on a call?" And I'm like, "Good God, man!" Like, yes, like, just because you're putting the uniform on does not remove the human from who you were. And I think we have to remember to incorporate that, because, and you're right, it's not just police officers, it's first responders, it's people as a whole. Whatever your profession or your title is, we get so caught up in the habit cycle that we take for granted the simple things. And when I'm teaching in hospitals or clinical staff, what I tell them is, look, don't take for granted the fact that because your job capacity allows you to ask people very personal questions, like, do you have a mental health diagnosis? If they answer you, don't just move on to the next question. Take a moment to appreciate the fact that they just gave you something very personal, but instead we just like checklist it. And it's like, name, birthday, diagnosis, medication compliance, who's your doctor, and it's like, whoa, like, yeah, we can get through the checklist, but what if we made it into a conversation? And so I remind them that, yeah, if someone's telling you they have a diagnosis, what's wrong with just pausing and saying, hey, thank you for sharing that with me. I appreciate you trusting me enough to give me that information. Just that little statement reminds that person that is in crisis, that maybe is overwhelmed, that maybe is afraid or unsure, that, oh, this is a person that's actually like seeing me as a person, and they're not just here to do their job. And it allows for a much more favorable outcome.
Yeah, I think it's something that we even teach teachers. Like we when we go in and think about response, and it's like, how do you ask open-ended questions, which we saw in that 20-minute, like you didn't ask yes or no questions, right? It was open-ended questions. It allowed them to guide those conversations, but those affirmations, right? The thank you, like thank you for sharing, thank you for allowing me into this like very critical moment in your life, can mean such a difference because you're building that relationship. And I think you saw it there in the clip too. I don't trust you. I don't trust you. Well, let me show you with my actions, right? It's not about my words, it's about my actions. And I know we didn't see it in the short clip that we saw, but even the getting on someone's level, like that's something that we like. I work with youth. That's something that we train all the time. Like just get on their level. Like it's less threatening to them. They're going to be a little bit more open to the whole situation. And I think even that, like sitting down on the ground, like you're in charge now. Like, hey, this is your moment. You're in charge. I don't feel threatened right now. I want to try to help you. I think those were huge. We did
And
get
I
a
think,
question. Oh, go ahead.
oh, pardon me. I just to tag on to that, I think you hit on something so important. Is I think we really have to view a crisis as people often feeling out of control. And so anything we can do for people to feel comfortable and regain some of that control, because usually the crisis itself makes you feel like you don't have control of your own faculties, or you don't have control of the process, or other people are telling you what to do. Anything we can do to model, this is really in your hands. We want to help you get there, but my job is not to tell you what to do, and not to try to push you into one thing or other. It's to be here for you and help with anything you might need. Simply giving that control back goes a long way towards making people feel more at home and building rapport.
Go from ask, tell, make to notice, talk, and act. That's our tagline. But and we did get a question from the audience that I wanted to pull in just to this conversation, because we were talking a little bit about the habits of police and emergency rooms kind of having that cadence, and this question is a little bit related to that. How do you shift the culture of those within the police departments who view arrest as the measure of success versus maybe a model of mental health and public safety as maybe the true measure of success?
So I'll just start with the first thing that's coming up for me is, any culture is such a difficult thing to address and tackle, and because it means so many different things to so many different people. And but as far as law enforcement goes, just as a in group, as referred to by sociologists, right? I think it's simple to just say, hey, how's it working for you? We can keep doing things the same exact way that we've always done them, but how's that working out? I think most all police officers in this country right now are intelligent enough to just wake up and realize that there's a shift happening, and there's really like two options. You can either stay open and listen and learn and improve, or you can resist it and just kind of get steamrolled. And so I think when it comes to addressing the things that actually need to change, and part of that, to your point, was how do we look at like the metrics that matter? So much of even just the perception from the public is, it's not always based on facts. It's based on whatever story or nuanced thing they've heard. This whole thing about like whether it's police having, some arbitrary metric that they're going after, or quotas, or whatever it is. The bigger issue here is that, nothing in policing is the same in this country, even within one state. Their training, the standard training that they get, the length of training they get, who's doing the training, the uniforms they wear, the rules and regs, the SOP. There is absolutely nothing that is the same from one jurisdiction to the next. And the problem with that is that in every city, in every county, in every state, in every community, people live there, and people have the same expectation. And that's that you're going to show up and treat me right, that you're going to maybe be patient, that you're going to be slow to react, and maybe be curious and have a little empathy. But those aren't the things that we're learning. Those aren't the things that are being taught. That's like the first day of the training academy. The commander comes in, reads like the ethics, and goes over like, hey, we're going to treat people right and like do the right things. And it's like, yeah, okay. Followed by months of fear-based tactics, injecting paranoia. You're going to die. This is a dangerous profession. People are bad. They're going to kill you. Sit with your back to the wall. Everyone's going to get you. Now go serve your community. And those two things cannot coexist. And so again, I'm not surprised why the problem is the problem. We have to look and anywhere I go and speak to law enforcement groups, I tell them, like, we have to own our portion of this, right? It's not like, oh, everything's terrible and how dare they don't know, they don't know, they don't know. And it's like, that might be true, but also we have to be honest with ourselves and say what we're doing is not working. It does not work. And our communities are demanding more, and rightfully so. And I do think that there needs to be massive reform within policing. And I think that we have to take a hard look at what are they being trained in? What are they learning? And how much of that is relationship-based policing that focuses on humanizing that approach versus reaction-based policing that focuses on staying afraid, everyone's a threat, you could die at any moment. When that's the track that you're on, it's going to be very difficult to show up and connect with people.
And Joe, I remember when we started, some of the data that we were collecting was use of force used in this on this call. How many man hours did you spend on this? Did you do an involuntary commitment? And when they were setting this unit up, they were measuring success. I heard the question say, do you measure success in some units by the number of arrests? Well, for us, very early on, they thought that success meant more involuntary commitments and less arrests. But really what that tells me is we were still really relying on the most restrictive outcome to a call rather than trying to stabilize within that community, trying to find out what resources are available on the back end of this that we can wrap around and really partner on a multidisciplinary approach. And it was very difficult for leadership to buy into the fact that, oh, we have this many officers on this mental health unit, but why is the number of involuntary commitments going down? Are they not working as hard? And it's like, no, they're actually working harder because now not only are they doing jail diversion and keeping people out of jail, they're doing hospital diversions and actually de-escalating at the scene and making sure that there's follow-up on this. So it's very, very difficult to measure success in a mental health unit. Joe and I were partners for many, many years. And on the 12 years that I was on the unit, 11 for him, we didn't have any use of force. And you're talking about dealing with, like the doctor said, people in their most critical day, most critical moment in the 7th largest city in the United States. We never used force because we knew what we were dealing with. I think we also had some advantage in the way that we approached the situation in plain clothes. And it goes beyond that. But getting back to measurement of success, I think you have to look at what numbers aren't reported, and that is the number of use of forces. That is the number of de-escalations that took place in the field. It is not just jail diversion or hospital diversion. It doesn't matter that it took the officer 3 hours to spend out there. They now have rapport with a family member that feels comfortable calling the police and not terrified that the police are going to show up and kill their loved one. So these are very difficult to measure.
I think those are all excellent points. And the person who asked it, thank you very much. Culture eats process is a very common phrase in management. We can have all the best education and all the best teaching, but if the culture doesn't accept it or understand why you're doing it, it's kind of moot. And I think both Joe and Ernie kind of hit that on the head. I think there was a phase there for a while where it was almost as if you didn't want to have somebody in one locked environment, i.e. incarceration, but they were okay with that just transferring to another locked environment, i.e. a hospital. And the truth is, if we're doing our jobs right, a lot of these can avoid both of those milieus and get people to the least restrictive setting. And that's what we want to aim for. It's not as easily captured. So I just wanted to thank the person for bringing it up because it's a really important point.
Yeah, and it got to, one of my questions that I wanted to ask later down the road. So, and that was around the 60% of police training is around how to shoot a gun, right? Like that was brought up in the documentary. And I think that, Joe, you summed it up even more than what I think even the documentary touched on with that, the fear that gets placed into that. Ernie, I am wondering, in the documentary, you did mention how important it is for police departments to collaborate with their local mental health authorities. Some locations obviously easier done than others. If they really want it to be effective in this work to help divert individuals with mental illness away from the criminal justice system towards the support and care that they need, what recommendations do you have for those collaborations? How do you get them started, or how do you make them really good allies and partners?
Well, what we did was we set up a meeting, and we had somebody buy a bunch of tacos and asked everybody to sit down at the table and have a conversation. Because the police department was siloed in doing what they did. The local mental health authority was siloed in doing what they did. Neither one of us spoke each other's language. And it took sitting down and actually listening to find out, you know what, we're servicing the same people. Why aren't we collaborating and doing this better? And I do go around and tell people, you have got to collaborate. Here in Bear County, the local mental health authority controls the bed at the state hospital level, and they're always at capacity. So, when you have a patient that's high acuity and needs some longer term care of treatment, you've got to learn to collaborate and work with your stakeholders within the community so you can get the best possible care and treatment for somebody to be placed into recovery, because recovery is very possible. And when we're talking about mental health, so it takes an open mindset from leadership, and not, that fixed mindset of, well, we're going to do things the way we've always been doing them because we really don't know any other way. It was a perfect storm for me. We had new leadership coming in from the police department. We had new leadership coming in from the local mental health authority. I got handpicked to be in this unit that I really didn't know how it was going to work yet. And then I was sat down at a table and saying, okay, what is it that the police department expects the local mental health authority to do? And my response was expedite the process. And the mental health authority said, well, then we need to let you know, what type of patients that we're looking for and how you can do a better job assessing them in the field. So we would like to put clinicians with you to help you in your learning process. And that was perfect. That's exactly what happened. Joe and I ran calls easily for a year, doing nothing but mobile crisis. So as these calls would come in through the mobile crisis line, we'd have a clinician jump in with us, or we'd follow them there. And we did the hardest thing for what law enforcement is. We showed up and we shut up. We knew very quickly we had to get out of the way and watch the clinicians do their job. And then we listened to them call the doctor and staff the case over the phone for best possible outcomes. And it was amazing. I mean, you couldn't have asked for a better system at that time from leadership who bought in and said, whatever you need, we're going to support you to make this happen. And when other entities saw that, other inpatient care systems, fire department, adult protective services, all of a sudden everybody wanted to get on board. And these meetings just grew and grew. And then we had people sponsoring CIT training, sponsoring lunches, sponsoring breakfasts, and saying, what can we do to be a part of the process in the community to give a better outcome for mental health? So it just takes being humble and saying, I realize that I don't know it all, but I'm willing to try to understand what you have to say.
Joe, do you want to add anything along the lines of how mental health treatment providers can be the best kind of partner for those police officers and those police departments, and kind of what in the role that they might play?
Yeah, so it's a huge piece of it, because again, one of the things that I learned early on was, and again, I see this so much because I'm fortunate to do a lot of these trainings, but when the officer is handling it, they see it as like a first aid, right? Like, I'm just gonna stop the bleeding. So whatever I can do to de-escalate this person enough to get them to the next level of care. The problem is, sadly, is the next level of care isn't always the best level of care. And because we're in the business of people. And I've seen it enough times where I would tell someone when I was new and I didn't know what I was doing and I was super nervous, and it was just like, let me hurry up and get you to the hospital because that's where they're going to help you. And then you get them to the hospital, and the first thing out of the nurses or the doctor's mouth is like, you want to kill yourself? Like, well, what are you here for? And it's like, whoa, now they're spiked up, they're escalated again. And it's like, what just happened? And there's 1,000 of these stories. So then I realized, okay, the only thing I can guarantee is my interaction. But I also knew that, the same thing that we're suffering from in the field from first responders is the same thing that the treatment providers, the nurses, the techs, the ER doctors are suffering from in the hospitals. In ER, and I learned this early on as well, is like, I think, and maybe it was here, maybe it's national, I don't know, but they said in a meeting, like, hey, look, we're trying to turn that bed every 3 hours. And when we have a behavioral health patient come in that's just sad, and they're tying up a bed, they don't have insurance, we got to do labs, and they're there for 10 hours, we're losing money. And then I realized, like, oh, this is a business too. And I can appreciate it now that I've seen it from a zoomed out lens. But initially, I was really offended by it. But I think there's a point here, which is nobody really understands the other person's perspective or the other person's position. And the hospital, the treatment providers assume or think that the police should do something a certain way. The police officers assume or think that the hospital should be doing something a certain way. And anytime we have an expectation of anybody, you're making an appointment with disappointment. And so I think it was just having these meetings where we could come together, learn from each other, understand the processes that were in place, allow the hospitals to learn from us. Then they started asking us to come in and actually provide them with training, like providing them with communication training and how to speak to law enforcement. And that was a very proactive thing to do, because again, there was a lot of like strife, because these nurses and doctors are like, yeah, I don't have bed space, I don't have capacity to take this person, but because of EMTALA or something else, like I can't turn them away. And so now I'm just mad about it. And so the officer gets treated poorly, the person in crisis gets treated poorly. And then there's like, well, what's the point of this? So anytime I dealt with someone and I had to transport them, I would let them know, look, I can guarantee you I'm going to treat you right. I can guarantee you I'll listen to you. But I don't know what's going to happen when we get to the hospital. I mean, I'll tell you where we're going. I can tell you the process. They're going to take your vitals, put you in a gown and all that. But how you're going to be treated, I have no idea. And the reason is because the same, I can't guarantee you what's going to happen if in 3 weeks you call the police again and you get another officer. Like, we all have bad moments and bad days, and that can just be okay. But I think that the expectation should be that even if we're having a bad moment or a bad day, we remember. And this is, again, when anyone asks, like, so what do you do for your business? And I tell them, I'm in the business of helping people remember. And they look at me confused, and I say, look, I just remind people of, no one's forcing you to do what you do, and you used to love the idea of this. So what happened? And when we can start reflecting and asking ourselves these tough questions of like, remember when you graduated school with your degree, or you first got into the field, or your residency, or whatever it is, how excited you were, what happened from then to now? And typically it's probably a moral injury coupled with a lot of just compounded stress and, dealing with a lot of very complex issues that the system is not built to support. And so every single component has weak points, and every single component has things that we wish could be better. And that's from the 911 dispatchers to the lack of community support, to the lack of capacity to treat, to funding, to all of the things. It's not one fault or one blame. It's a collective thing that I think absolutely needs to be improved upon. But that's what I got for that.
I like the way you put that, Joe. And I think it's one of my favorite things about the collaborations between law enforcement and mental health is you break down those silos. Because just as Ernie mentioned, I think there is a lot that law enforcement can learn from mental health professionals. We also learn from law enforcement. We learn a lot about frontline situations. Some of the best people with de-escalation and people skills I've ever met are in law enforcement. And so we do have that really nice two-way form of respect for each other in education. And you also call out another point, which I think so often is a lot of people in both of our lines of work really are hopefully very much fans of wanting to help the person. And even when things are very, very stressful, they are professionals. And so they never take that out on the person. But sometimes, at least in the world of mental health, you displace it somewhere else. And so it's very common when you see whether you are a nurse or a security guard or law enforcement or EMTs or fire, you tend to see things happen between each of us because we're displacing the frustrations over the systemic issues upon each other. Why? Because it's a safe place to displace it. But the nice thing there is then we can reflect upon it and then use those lessons to further help the people we're trying to serve. So I love those collaborations for that reason. I think it's very neat to see each side see the similarities in the similar stresses that we face and the similar challenges that we have, and also the similar rewards we get when things go well.
Love it.
Yeah, I think a point that I really want to, I think, expand upon here is that these are not problems. These are individuals. I think, Joe, these are people, right? These are community members. These are neighbors. And when as a society or as a community, we look at them as a problem because they're taking up bed space in the emergency room, or they're taking up call time from our police officers, or they're causing a ruckus, in the middle of downtown or whatever that is. They're still our community members. And I think if we can get, and I guess using Joe's point, if we can ask them the why, what brought you to this point, if we could try to figure out what brought them to this point, maybe we could figure out how not to bring them back to that point as well. And Dr. Thrasher, I'm wondering, how do we encourage the creation, implementation, and funding of community response teams that removes police officers as that first responders to mental health crises to begin with?
Absolutely. I think as you look across the country, you see a lot of innovative ways to do this. I can tell you here in Milwaukee, we've had a community non-police response for decades that we run. That being said, we also have collaborations of a mental health clinician with law enforcement. So we see kind of how both sides can bring benefit to the equation. A lot of it, in my opinion, Chris, still does come down to funding. And funding leads to rapidity of response. I mentioned that in my first answer to you is when somebody's having their worst day, the last thing they want to hear is, well, I'll be there in about 45 to 50 minutes. And when you're in a city the size of San Antonio or a city the size of Milwaukee, it doesn't take long for transport time to get slowed down. So I think one thing we need to see if we're going to take that approach of the mental health presence first on scene is to see it budgeted for and staffed at the same presence as you would with EMS or fire, for instance. You wouldn't see a city that would probably tolerate somebody say, well, if you have a fire on third shift, we just can't get to you. We'll wait till the morning and then we'll see what we can do with your burning house. That would not be acceptable. And trying to make a mental health crisis or any crisis equitable to that type of fire EMS really could give some more funding and staffing to it. And by that, I definitely don't mean taking funding from others. I think just creating the space and recognizing it, and that will help with decreasing stigma as well. Because just like you referenced in your last add-on, once you start seeing these actual crises as equivalent to other medical emergencies or other community emergencies and not a burden, it's not the person's fault, but they deserve the same type of care and treatment that it would if I was having a heart attack, having a seizure, or my house was on fire. That would make a big difference. So it's really going to come, in my mind, down to that supply and demand. Because when you are in crisis, the idea of, yeah, I can get a mobile team to you in 35 minutes doesn't sound as good as if I call 911 and somebody's there in 2 to 3 minutes. And so how mental health systems are funded is also very important there. I know a lot of good programs that are Monday through Friday daytime hours, and those are admirable, and I'm glad they're there. But Monday through Friday daytime hours is about 27% of a total week. So unfortunately, that's not when most crises occur. The majority happen in the other 73%. And how do we staff those? Well, I know how fire, EMS, and law enforcement staffs them because they are staffed 24/7. Not all mental health mobile type of responses are. And so I think that would be my first step. I know saying it's about funding is never the most exciting answer, but I really think the funding ties to that, not only the equity, but also the stigma, which is something we're talking about right now, right? Is trying to find a way for individuals to be treated with the same amount of respect they would with any other emergency. And I think that would be a good first step. I think if you can increase the funding and get it after hours, then there could be less of a supply-demand divide between that of the law enforcement world and the mental health world.
I've got to jump in on this one because when you talk about funding, everybody wonders, like, how do we make this happen? Last year, Bexar County came up with an initiative called the Program for Intensive Care Coordination. And what they did was the hospital systems, we had about 6 of them here, identified the top 100 highest mental health utilizers that were walking into their hospitals or treatment facilities and being involuntarily committed or just using up a ton of their resources. So what the hospital facilities did was they put in some money into a pool. It ended up being about $1.2 million. And this PIC program was born. And what it did was it partnered a police officer, mental health unit officer, I was one of them, with a paramedic and a clinician from the local mental health authority. They also provided, the local mental health authority provided a psychiatrist for those 100 patients. And because it wasn't grant funded, the money wasn't earmarked for anything specifically. So we already knew who the patients were. We did not wait for the crisis to come in. We were proactive, went out, contacted the patients that we knew were already coming through the door. and saying, why are you coming through the door so much? And we had answers such as, I have no access to care. I have no money for medications. I have no housing. I don't have any kind of ID, so I can't stay the night at the Salvation Army. I don't have transportation. So we were able to close all those gaps because we could use those funds. I was buying packs of cigarettes for people if they would come in a field and give injections if we needed that. So we didn't have to rely on a patient coming in, although I felt like my full-time job was an Uber at that time. But what we found was the data showed that on average, when we started the program, these patients were being involuntarily committed 1.62 times a month. After 1 year, it went down to 0.92, right? So less than one time being admitted at one of these facilities. And the cost savings was astronomical. And now this is a fully funded program that's sustainable anywhere. So it just took the community stakeholders to come together to say, is there a way to make a better approach? And the hospital systems and provide access to care within the community that would relieve a lot of the pressure in the emergency room. And that's exactly what we did.
And I think that in Dr. Thrasher, I think the funding, I think that's, we see 24/7 psychiatric emergency drop-off centers, but they're few and far between, even the access to that. And I think, especially as we look and continue to support kind of the expansion of 988, it's that true investment in community mental health supports and truly building up a system of crisis support that needs to be done across the country. And I think it's going to take a lot of money.
And what I liked about Ernie's example too is it really needs to be funding from everybody. Because once again, one of the biggest stigma I've always seen in working with people with mental illness is, well, that's not my job. That should be theirs. Or, well, they can't be here. They should be there. And it's unethical. It's horrible to hear, but it happens all the time. And so I think the more, like Ernie said, you really get buy-ins from all aspects of the community. And I want to use my earlier example. If you need new funding for fire and EMS, there aren't certain parts of the city that say, I'm not going to do it. Everyone equally. And I think when that happens, it gets a lot better quicker, even when it means opening the checkbook.
We got a question in from the attendees, and I think it relates to this conversation we're having right now. We've talked about mental health providers, we've talked about police officers. What can the average citizen do to help change the process, the culture, when we look at this response?
I think if we look at, one of the things that I've been saying for a while to address this point is, I think the fastest, most efficient way to significantly reduce 911 calls to people experiencing a crisis is if people understood anything about mental health. And I think American has to go through a basic 8-hour mental health first aid. If we just had a base level of understanding, again, you don't have to be a Dr. Thrasher to know that, like, someone's in crisis. But because we lack the confidence to go and address somebody in crisis, because we lack the understanding to communicate when someone is in crisis, we avoid it. It's like, see something, say something. And so someone who is simply symptomatic of their mental illness gets a 911 call. And then police who are not trained most times are showing up to those calls. And sometimes it's a good outcome, sometimes it's not. And so I think, again, that's just that would be such an easy thing. It should be part of grade school curriculum. I think it should be mandatory, not as an elective, but I think we need to, that's how we can.
Oops, it looks like we might have lost.
I know where he's going with it because I think we can finish each other's sentence. Are you there, Joe?
Yeah, I don't know what happened there. Just
okay, there you
kick
go.
me out.
Go ahead. Keep chatting.
Sorry about that. But, it needs to be a part of standard curriculum throughout. And I think age appropriate, like it should be in elementary school. It should be in middle school. It should be in high school. And the more we can have these kind and address things, again, I think one, you're preparing people to be adults in this country and thrive and have a lot better lives. But you're also creating a sense of awareness and a competency that goes along with what is mental health, and even how we talk about it, right? I think if we could just accept that, like, mental health is a spectrum, and on one side is mental illness and the other side is wellness.